Okay, it's 6 o'clock, and I'd like to welcome everyone to our open house for the School of Allied Health Sciences. If you are attending this in person, you'll have a chance to either chat in or raise your hands to ask us questions throughout the open house. If you're watching this on YouTube after the fact, these are the presenters, the names that you see in front of you. And if you want to ask us questions, you have our email addresses, and so you can reach out to us even if you're watching this on YouTube now. So again, welcome. We're going to talk a little bit about our school and what we have to offer, and then we thought what would be interesting is to have some presentations that discuss our different disciplines in the context of the COVID-19 pandemic that we're experiencing right now and how our work relates to that. But of course, we are eager to take any questions anyone might have about our programs with respect to anything about our programs at all, not just COVID. So with that, let me just introduce our school a little bit. And if I can, I would welcome you or invite you to explore our website. This is the URL for that, but you can, of course, find it very easily through simply Google searching the School of Allied Health Sciences or going on to Boise State and searching for us that way. But you'd be able to see a little bit about our programs, and just as a little bit of an introduction, we have many different opportunities in our school. We have a number of professional licensure programs in respiratory therapy, ultrasonography, X-ray, CTI and MRI, athletic training and genetic counseling, which are graduate level programs, and also in physical education. We also offer opportunities for students who want to pursue undergraduate degrees that prepare them for other professional school opportunities. For example, we have programs that are very nice for students who would like to be pre-med, pre-dental, pre-PT, pre-OT, pre-physician assistant, and many other things. For example, 2 out of every 3 students that gets into PT school is a kines undergrad major. So there are just a lot of options for that. If you want to look at how our degree programs align with these different professional degree programs, you can click on this link on our website and you'll be able to download a document that looks like this. And it has all the different degrees that we offer across the top. And it has a whole bunch of different professional professional school opportunities or professions that you could go into with those degrees. With the green meaning the program is really kind of designed for those students, and the yellow meaning it may not be designed for that type of student, but it certainly would work for that student. So that may be of use to you. And then, of course, we have graduate programs as well in a number of fields. And so we would just invite you to explore all of the different opportunities. And also on our website, you can go to our different department web pages and look a little more detail about what the requirements of those programs are and contact information, and to get a little better sense of the things that we do in those areas. So that's just to offer some introduction to who we are. And from here, I'm gonna stop sharing my screen, and I'm gonna introduce to you our first presenter is Jennifer Eichmeyer, who's gonna talk a little bit about her work in the area of genetic counseling and some interesting information that she has for us. So Jen, take it away.
Thanks, Bob. Hello, everyone. So I'm going to talk a little bit about genetics and how they influence your risk for COVID-19, as well as genetic counseling. So let's just jump right to it. Do your genes influence your risk for COVID-19? We don't know yet. And there we go, I'm done. I'm not doing anything else. No, just kidding, just kidding. So very little is known about the individual responses to COVID-19 in regard to genetic information. We do know that there are differences, and differences exist because we can see variation in disease presentation. And those differences range from cases with no symptoms and cases with very severe symptoms, which involve acute respiratory distress, and that can be fatal. There are an excess number of men who suffer from severe infections, advanced age, cardiovascular, pulmonary and renal disease can also influence the way that we express the disease, but we're also seeing the disease in young and healthy individuals too. There's some talk that blood type A, may be associated with a higher risk of contracting the virus, whereas type O offers more protection, and there's not really a lot of known information about why that might be. But it's really important to note that these are observations, and correlation is not causation, meaning just because we observe differences, it doesn't necessarily mean these differences are caused by the thing. And I like to use the example of umbrellas and raining. Umbrellas are definitely correlated with rainy weather, but umbrellas don't cause rainy weather. And that's kind of what we're dealing with here with genetic information. So I want to do a very, very quick review of basic genetics, and hopefully it's not too boring. So this is known as the central dogma, DNA to RNA to protein. So our DNA is the instruction book for how we are built and put together. And since the DNA is a double-stranded chemical molecule, it needs to be transcribed into a different molecule that can be read by the cell. So this molecule is known as RNA. And so RNA is a single-stranded molecule, making it possible for the cell to read and translate the genetic material into a protein. And proteins are what actually have a function or a job in the cell. So you can think about it as the DNA is the recipe book, the RNA is the chef interpreting that recipe, and the protein is the entree or the product made from the recipe. And this is obviously a very, very simplified explanation for what is in reality a much more complex process, but for our purposes, it will serve well enough. So now let's think about how those proteins we were talking about, and those proteins that are specifically part of the immune system, might play a role in how we express COVID-19. So we can start thinking about what genes make those kinds of proteins within the immune system that actually might have a function with these different questions. So when a virus infects a cell, it takes over the cell and forces the cell to make proteins from its own RNA. So these RNA viral proteins are presented on the cell surface as antigens, and that usually induces an immune response in the body with the production of antibodies. Antibodies, or the immune cells, have receptors that match the antigen from the virus, so the cell can be identified and destroyed, thus killing the virus. But some people make different kinds of antibodies, or they make different receptors on their antibodies because they have changes in the genes that make those proteins different. So these individuals might not have the same kind of immune response. It may be bigger, it may be less. And so that could be an influencing factor in how they respond to disease. So what are the genes of interest with COVID-19? There are several genes that researchers all over the world have identified as potential genes. ACE2 is a cellular receptor, which means it makes a protein that helps the virus bind to the cell. TMPRSS2 is a cellular protease, which means it helps facilitate virus entry into the cell and may be influencing severity of the disease. The HLA genes are involved in the immune response, and HLA4601 may be reducing the viral antigens present on the cell surface, meaning there'll be less of an immune system response. Whereas HLA-B 1503 increases that antigen presentation, suggesting these individuals may be more likely to have a higher immune response and more immunity. And then this last group of genes are part of the cofilin complex. It's a series of genes, and they've been implicated with the HIV infection. So because they've been implicated in another viral infection, they're of interest to researchers for COVID-19. But I want to point out, these are all maybes. We don't know for sure. We definitely don't have enough data, and it's not going to be available for clinical testing for a very, very long time. So there's still a lot more research that needs to go into this. So now I'm going to talk a little bit about genetic counseling. What is genetic counseling? Well, basically what I just did. You take information that's very complicated, you break it down into something that's easier to absorb for people who have different variations in exposure to science information. Genetic counselors have training in medical genetics and counseling skills. It's a Master's of Science 2-year degree. And I promise you, we are a lot more articulate than talking about long, twisty, ropey, laddery things. So what do? Well, the first thing that we do is we identify people who are at risk for genetic disease. There are a lot of different indications for coming to see a genetic counselor. Some people come to see us on their own because they're curious about their family history. And then the next thing we do, which is probably the biggest thing we do, is we educate patients. We actually are teachers, and we teach people every day, every patient, about genetic information. And again, we make it accessible to them so that they're able to make decisions about their health care using that information that they learned. A lot of times people are wondering, how did this get in my family? So we talk about inheritance, recurrence risks. We talk about the risks for other family members. Of course, we talk about genetic testing, how we do it, we can coordinate it, interpret the results for individuals. And then once we do have that genetic diagnosis, we can talk about the now what. What do we do with it? What are the options? How do we change medical management? What research options are there? Are there support resources for individuals? And so genetic counselors tend to specialize. Those of us that are in cancer, we tend to see families with family histories of colon cancer, breast cancer, endocrine cancers, kidney cancers. Those of us in prenatal tend to see pregnant women or couples wanting to become pregnant. Oftentimes there might be babies that have ultrasound abnormality or an abnormality on a screening test, and we'd be talking about genetic testing. And then we also work with medical geneticists in the pediatric and adult world, where we do clinical evaluation. So these are individuals presenting to us with all kinds of things going on, and we try to put the pieces together to give them a genetic diagnosis. Genetic counselors can specialize in neurology, cardiology, ophtho, and other areas. So hopefully you can see that this has been a real-time example of what a genetic counselor can offer the healthcare team. And we've seen a tremendous amount of growth in the profession. There's a lot of demand for us, and we're thrilled to be able to offer a genetic counseling degree here at Boise State that's fully online. So for more information, I've put our website up here, and if you have any questions, you can reach us at that email. And so I will stop there, and thank you for your attention. Bob, did we want to do questions now?
If we have any questions, folks, you can either chat them or raise your hand, or any of the above. I don't see any questions just yet. So what we'll do is we'll allow people to chat in questions at any time for any of our presenters. And then we'll also have time at the end for general questions. So with that then, I will introduce Lonny Ashworth, who is our program director currently for the Respiratory Care Bachelor's of Science degree program. And so Lonny's going to talk with us about mechanical ventilation, I think. Yes, Lonny, it's all yours.
All right, thank you. Hello, everyone. I hope that you're doing very well. So I'm Lonny Ashworth in the Department of Respiratory Care. In our department, we have 3 separate programs: a 4-year Bachelor of Science degree program, an Associate to Bachelor's Degree Advancement program, a Master of Science program. We have 11 full-time faculty, 3 professional classified staff, and we use many clinical adjuncts and professional adjuncts throughout the nation, actually. Our four-year bachelor's program is normally it's an on-campus program. However, since March it's been an online program. We're hoping this fall we'll be back at least in the hybrid model. We have 5 full-time faculty. We typically graduate 22 to 26 students per year. Our students are highly recruited. They obviously work in the local hospitals, but when you look at the list of hospitals, these include the major hospitals throughout the nation. Our previous graduates have done a wonderful job of getting prepared, representing Boise State well, and our students are welcomed with open arms. And even the last couple of years, they're at different places like Mass General, Johns Hopkins, Cleveland Clinic, Duke, etc. Our AS to BS degree advancement program is strictly online. We have 4 full-time faculty. We now have graduates from every state in the nation, and they graduate about 160 students per year. We also have a master's degree program that started 2 years ago. It is strictly online. We have 2 full-time faculty and many adjunct faculty. We will graduate our first class this August. They will typically take in 18 to 24 students. We have students spread out across the United States, and in our second class this year, we even have a student from Japan. There are less than 10 accredited master's programs of respiratory care in the nation. So now what Dr. Wood wanted me to talk about is the coronavirus and how respiratory care has been involved with this. As most of you know, and as Jen just said, the COVID-19 patients suffer from a very severe respiratory distress. Because it's a severe respiratory distress, respiratory therapists are a key to their treatment. Their treatment will always involve oxygen therapy, and in some cases, a very high level of oxygen therapy. Some cases, we will use non-invasive ventilatory support, and in some cases, we need to use invasive ventilatory support. Many of you probably are very familiar with non-invasive ventilation, like mask CPAP or BiPAP for obstructive sleep apnea. During this time, we're trying different type of interfaces to help reduce the spread of the COVID-19. One of them is a full face mask. However, this one is a hood. It looks kind of strange, but actually some of the latest data is showing that this might be a very effective way to ventilate some of these patients, provide some ventilatory assist without spreading the disease as easily. However, many of the patients end up needing invasive ventilatory support, which means that they need to be intubated through their trachea or have a tracheostomy if they're going to be on the ventilator for more than 10 to 12 days. Now, everybody has heard about the shortages we have now because of the COVID-19 pandemic. We have a shortage of properly trained personnel. We have shortage of supplies, including PPE. But with mechanical ventilation, we have 2 primary shortages. One of them is personnel related, meaning intensivists and respiratory therapists, and the other one is for ventilators. Early on, when we were watching what was happening in other countries and watching what was beginning to happen in Seattle and in New Jersey, it became very obvious that these are very extreme times. And we had multiple people call and ask if there is any way to ventilate 2 patients with 1 ventilator. I had never truly believed that this would be necessary. However, because of the situation that it was in, we did develop a way to do this. So Camille Stover, one of our faculty, Mike Perda, one of our graduating students, Dr. Joe Coyle, our current chair, and I spent a bunch of time trying to find a very good, safe, effective way to ventilate 2 different patients with 1 ventilator. We produced a video, and it was distributed literally worldwide. And we had calls from all over the United States and other places within the world asking about this. Some other people also developed videos for this. Some of those I have concerns with. One of them listed that you can ventilate up to 7 different patients at once. Well, yeah, you could ventilate 7 different mechanical test lungs, but to ventilate patients, truly, I think you can do it if you're very knowledgeable about mechanical ventilation and the ventilator and the disease process, and you do proper matching of patients. It can be done safely with 2 patients. However, most of the professional organizations like the American Thoracic Society, the American Association for Respiratory Care, and many more came out with a paper strongly against ventilating 2 patients with 1 ventilator. Shortly after that, the FDA came out with a paper, and in their emergency use authorization, they included dual patient or shared ventilation because of, as they put it, the extreme times we are in require extreme measures. So it can be done. It is being done. It was done successfully on the East Coast. We talked about doing this in the Boise Valley. I met with 3 different intensivists, and we went through, looked at everything. We were prepared to do it in the valley if needed. Luckily, we didn't have to. Hopefully, we will never have to. However, it can be done.
Lonny,
Yes.
did you want to share your screen? I wasn't sure if you were there yet.
Okay, now can you see that?
Yes. Yes. I'm sorry to interrupt, but I didn't know if you were.
No, thank you.
Yeah, that's okay.
Okay, now you can see the ventilator.
Yes.
Okay, that's very appropriate time to get it.
Okay.
So this is a typical non-invasive ventilator. In fact, this is the most common non-invasive ventilator used in the world. And it works very well non-invasively. However, it can be used invasively for these patients in the correct modes. There's different modes on it, but if it's used properly, it can be. Now, what we did is we connected a Y piece here, and we can ventilate 2 separate patients with this device, actually fairly easily, and it does a fairly good job. This is an adult critical care ventilator, and this can be done on any of the adult critical care ventilators where the inspiratory limb is split off and it goes to 2 different patients. We have valves in line to prevent cross-contamination. Then the gas comes back from each patient. Again, they go through valves to isolate each patient. It then goes into the expiratory valve and allows the patient to get ventilated. So these do work. We have tried it on multiple devices and testing, and it is working well. Now, even though the professional organizations came out against this, when we first developed this, I called one of my friends who's director of respiratory care at Mass General in Boston, and we FaceTimed on it. I had him look at everything, and he felt it was appropriate also. And he said, in fact, we're working right now on an article to show the same thing. This is the article that he was working on, and it includes 4 of our leading researchers on mechanical ventilation in the world. It was just published this month in the American Journal of Respiratory and Critical Care Medicine, showing basically exactly what we were doing. Now, we are also contacted by 2 different industry partners asking us to assist them. One of them heard that we were working with dual ventilation, and they asked us to help work developing a monitoring device that will allow them to monitor individually 2 separate patients being ventilated on a ventilator. That has been submitted as a grant in which we're a part of. That's been submitted to the Air Force. A second company asked if we'd be interested in helping develop a mass casualty ventilator. We did. That prototype has been developed, and they are working on getting it ready for FDA approval now. So one of the things that happened in 1994 is I became involved with Japan education when I met this guy, Dr. Toshihiko Koga, in 1994. Because of him, we've been doing workshops in Japan since 1995. All of the workshops are hands-on. Some of them are less than 10 people, some are more than 100. Now we spend about 4 weeks a year doing workshops in Japan in the winter and 6 to 8 weeks in the summer, except for this summer. Now we're doing Zoom workshops instead. As of this May, we've presented more than 300 workshops to several thousand people over there. Another thing that we were asked to do in Japan was to produce videos for the non-ICU physician over there. So we created 5 different videos on different areas of mechanical ventilation. That has been sent over and it's been translated for the Japanese physicians and co-medical personnel. So none of the Japanese connection could have happened without Dr. Koga. So anytime I talk about Koga, I have to thank him. He died before we were able to reach his dream, but we're continuing to work hard for that. Now, respiratory care is a vibrant field that unfortunately, in some ways, people are hearing a lot about respiratory care right now because of how bad these patients are. However, respiratory care is a wonderful field. You have a lot of different areas you can go into: neonatal, adult, pediatric, in-hospital, critical care, transport, rehab, many different areas. If you have any questions, give us a call. My email address is there and our website. Dr. Wood had it on there earlier.
Thank you, Lonnie. So if you can unshare your screen, thank you. And so for those of you who have joined since we got started, this will be recorded and we should have it on YouTube, and we'll also email that link out to people. So if you've missed some things, you can catch it later. But now and thank you, Lonnie, thank you, Jen, also for your presentations. I'd like to introduce now Joie Burns, the Department Chair for Radiologic Sciences. Joie?
Hi, Bob. Thank you, and hopefully I'll get this right. So what I'm going to do today is provide you, well, here we started at the end. I want to start there. Sorry about that. A very brief demonstration of how medical imaging plays a role in our COVID-19 patients. So in radiologic sciences, we offer some of these different imaging modalities as far as educational programs. Not all of them, though. There are several across all of medical imaging. So a few that I'll show you today are angiography. This is really looking at blood vessels, usually with some sort of a contrast media dye, is what patients frequently call it. Computed tomography, or CT, which we do offer. Radiography, specifically we'll be looking at chest x-rays today. And we do offer radiography. MRI, or magnetic resonance imaging, is another area. We will look at positron emission tomography just because it does seem to be playing a bit of a role, but we do not offer a nuclear medicine program at Boise State at this time. And then ultrasound or sonography is the other area. I'm going to be showing you several slides today. I want to acknowledge that a fair number, most of these slides are from the RSNA's special focus page. They have put together kind of a repository, if you will, of articles and images that is available to the public. And so if this is something you're interested in, I strongly encourage you to check them out. So I thought I'd start with a chest x-ray. That's something you're we're commonly familiar with. So here you can see a normal chest x-ray, and we're looking at the patient from front to back, and we can see the ribs, the bones are all white. The lung is this dark gray area, and there's some blood vessels right here at what we call the hilum or mediastinum area. This is a patient with COVID-19, and you can see that that lung area is no longer that nice, consistent dark gray, but it has more of a patchy look to it. This is common with COVID-19, especially when we see it in both lungs. Unfortunately, chest x-rays are not very sensitive. We find that about 50% of patients who are positive for COVID-19 don't demonstrate any abnormalities on their chest x-ray. A much more sensitive modality is CT or computed tomography. So I'm going to show you a series of pictures here, and I thought it would be probably helpful to start with what a normal lung looks like. So here we have an axial image. So this is as if we took the human body and we sliced it up like a loaf of bread, and we pulled out one slice to look at it. And in this case, we're looking at the mid-chest. We can see the lungs out here. Again, they appear dark gray. We can see bones. Again, they're white. And then here we have the heart centrally and the aorta back here. CT is not restricted to only looking in the axial plane. It can look in the longitudinal plane from head to toe or from side to side, the coronal plane. This is a patient, by the way, that does have COVID-19. You can see it's quite extensive. We have these patchy areas in both lungs again. And then, of course, you can see that it can extend the entire front to back width as well. And here's just another patient. Again, the CT is very sensitive, and you can see these patchy, they call this a ground glass appearance, and we can see it throughout both lungs. Here we can see the air bronchogram where we have consolidated lung, and we actually have the bronchiole filled with air. And the only reason we normally don't see that, but since this is all condensed or filled, we can see that bronchiole. Here is another sign seen with COVID-19. This is called the reverse halo sign, and we can see this white ring around this this darker area. Another sign that we can see with COVID-19 is what they call the crazy paving pattern. The crazy paving pattern is actually, it looks like pavers that are malarranged, I guess, for lack of a better term, out of their linear orientation. And 3D, or excuse me, CT can reconstruct images, and they can subtract out the bone. It's actually pretty cool. You can see the lungs here. And again, both of these patients have COVID-19. We see densities, particularly in the periphery. These are just two different manufacturers, and so they've colorized the lungs. This is actually a video clip. I'm hoping it plays nicely for you, showing a rotating set of lungs with the COVID-19, so you can see that they can be viewed from any angle. And we're also seeing the bronchioles there. We can also use magnetic resonance imaging. MRI is a relatively expensive modality. It's very sensitive to for soft tissue changes. And in this patient, they found the patient had COVID-19 with all these opacifications, but had their condition worsened, and so they were actually doing this MRI for cardiac abnormalities, which are often seen. But you can see the lung changes as well, which were incidentally noted here. We can also do PET, positron emission tomography. This is a nice example of a patient whose condition changed over time. You can see a 4-day span. This is the 13th, this is the 17th. noting that this got worse. What PET does is it gives us a functional image as opposed to an anatomic image. And you can actually fuse the PET and the CT together. And that's what this fusion image is showing you. So you know what's going on at a specific area. Ultrasound can be used to look at lungs. Not commonly used so much in radiology because we do have CT and X-ray. But oftentimes pulmonologists are using ultrasound at the bedside. And so here we can see the ultrasound transducer being applied, and we can see the lung moving below, and that's what they call the sandy beach sign is demonstrating as normal lung moving. In this case, this patient has a collapsed lung or pneumothorax, and we see that there is no movement back here, and so that's one of the ways you would diagnose it on an ultrasound. Let's see if you're going to run. Here's a video clip. This just shows you ultrasound strength. It is a real-time modality, so we can watch the patient breathe. We can see the lung, which we shouldn't be able to see. It is filled with infection or consolidated up here. And we can see normal lung kind of moving in, and then this black is just fluid surrounding with the liver below. One of the other things that medical imaging can do is, of course, diagnose some of the sequelae of COVID-19. We know that clotting abnormalities and vascular changes and inflammation can go with COVID. And so these last couple slides just demonstrate how medical imaging is used in that way. This is a CT demonstrating a clot in a patient's aortic arch that can embolize, break free, and then float downstream. And in this other image that you can see, this area of the kidney, you can see a kidney here and a kidney here. This kidney looks different, this area, because it has actually had its blood supply cut off. It's ischemic due to an embolism. And then on our last slide, this is an angiography. This patient is a COVID-19 patient who had an embolism that went to the back, the posterior circulation of their brain. So the basilar artery here is obstructed. We can see the radiographic dye goes up and just stops. The physician went in, removed the thrombus, and then re-injected the radiographic dye, and we can see filling of that posterior circulation. So hopefully you can see that radiography plays an important role in COVID-19, and there's a variety of ways to look at the body and assist with therapy. So thank you, and if there's any questions, I'm happy to answer them.
Thank you, Joie. So we'll go ahead and move on. Again, if you want to chat any questions to any of our presenters at any time, you can just do that through the chat or raise a hand. But if there are no questions, then we'll move on to our next presenter. And I guess, Lonny, you're going to present on behalf of Joe Coyle. Joe is our interim department head right now, at least for a few more days in respiratory care. And he's unable to be here, but he did have a presentation, and Lonny's going to present that on his behalf.
And he may join in the middle. He does.
Okay.
He will take over. Okay, so as Dr. Wood said, Dr. Joe Coyle is our interim chair. Dr. Coyle is a critical care anesthesiologist who, for respiratory therapists working daily with an intensivist, is absolutely amazing. For us, we feel so very fortunate. So what he wanted me to talk about, or what he was going to talk about, is the role that respiratory care within our department has played at this time. One of the things that we have done is we have distributed or made available all of the critical care ventilators, the transport ventilators, the older ventilators, anything that would safely work to ventilate a patient, we have made them available to the Treasure Valley hospitals. Some of them had already taken them, they had already borrowed them from us. Most of the rest of them had them on standby, so that if they needed them, we would get them over to them immediately. Another topic that we did, as we talked about, was splitting ventilators, or the dual patient or shared ventilation that I already talked about. Something else that we did is early on, when nobody knew how bad it would hit any given area, the Boise Valley, Idaho, the Northwest, and we still don't know how bad it's going to be in the fall or the next time that it does, we do have an increase. However, it looked early on that we were going to have more ventilators than we currently have available. We would not have the staff to be able to train people. So Chris Carter, who is the officer from the CDC for the state of Idaho, contacted Lieutenant Hahn, who contacted Dr. Coyle, and Dr. Coyle, Clay Sanders, a CRNA, and I together worked on a large set of videos to help train non-ICU physicians and non-ICU CRNAs and non-ICU therapists, to give them enough information that they would be able to manage these ventilator patients. They still would be referring to one of the lead intensivists, but they would at least be able to manage these. And we'll come back to that in a bit. Another thing that we did is we had 2 of our students who were to graduate this summer. They each had only 1 3-credit course left. They agreed to double up on credits, so they ended up with 22 credits this semester. Dr. Coyle and I created a COVID-19 special topics 3-credit course for them. They were able to graduate in May. They're working now in the hospitals 3 months sooner than they would have been. Another thing that has happened within our department is our MSRC, or the master's students. Several of them have gone to many different hotspots within the nation to help out. They've left their home and moved, or commuting back and forth to Seattle, LA, Boston, New York, Atlanta, and Chicago. Now, Dr. Coyle would be able to give a lot more information about the biochemical part, or would have Jen jump in and let her talk about the biomedical part. But we know that with COVID-19, it was first noted in China in December 2019. Interestingly for me, I was in Japan in January and early February. So as this was coming out, I was in Japan, and we were getting rather nervous as we were hearing what was going on. We know that it's very infectious. We also know that people are able to spread the infection at least 3 days before they have symptoms. That's a very important part. We hear from some politicians that it is no worse than the flu. That is absolutely incorrect. It is at least 10 times, has a mortality that is at least 10 times that of the seasonal flu. Do not believe anybody if they tell you it's just the flu. In fact, I ran into one of our former students at Costco last week, and he said that he did test COVID-19 positive. He said he's had the flu in the past many times. He said, I have never been so sick in my life. He said, I thought I was going to die. He ended up getting better. Now with coronavirus, initially with stage 1, there's a very early infection. You get a viral response. Typically at that point, you either have a dry cough, diarrhea, possibly headache. Then if it progresses and goes to a pulmonary stage, which is stage 2, that's when it goes to this very severe shortness of breath. These patients are extremely hypoxic, very low oxygen level. They begin to get the abnormal chest imaging that Joie showed us as well. Then if they do progress on to stage 3, it is a severe hyperinflation phase, and they end up with a very severe ARDS that is very difficult to manage. And we're finding that we don't manage it the way that we manage the other causes of ARDS. It's a very difficult condition for us to manage. These are CTs. Joie showed this beautifully already, that you get this ground glass appearance in the lungs from the COVID-19 virus. And in this case, it gradually spread. Probably the key thing that Dr. Coyle wanted me to say is you need to wear masks. We have to continue social distancing and wash our hands. This virus attacks the alveoli deep in the lung first. So since it's deep in the lung, it might not be cultured in a nasal swab. And we need to make sure that we are using a mask to help prevent the spread of this, to help prevent and protect other people. This is a slide of some of the training that we did that I'd mentioned. The training initially was to CRNAs and non-ICU physicians. We had also set it up for internal medicine physicians, family practice docs, RTs that don't normally work in the ICU. Another idea that Dr. Coyle had, Dr. Coyle is a critical care anesthesiologist. So one of his ideas was we have a lot of anesthesia ventilators. So we created a video with the help of Clay Sanders, who's a CRNA in town. And we created a video showing how to adapt a anesthesia ventilator and use it as a critical care ventilator. These are our two students, Mike Perta and Kelly Riley, who agreed to take an extra 3-credit course and ended up with 22 credits in their final semester. They did a tremendous amount of work going through the COVID-19 course that we put together. They learned a whole lot about this. They had a great project that they were able to give to St. Al's for them to use during this time. And both of these guys are now working as RTs in the hospital. So RT has been very involved in this. It's been fun for us to see what we can do to help other people. And it really has involved our students, our faculty, our administrators, and some of our RTs across the nation and the world. If you have any questions, let us know. If you have any questions about the biochemical part, definitely send that to Dr. Coyle. Don't send that one to me.
Thank you, Lonnie. Okay, so again, please feel free to chat in any questions that you have. We have one more presentation that I will make. And so this has to do with kinesiology and COVID. And you're probably asking a question, what does kinesiology have to do with treating COVID? And well, I'm so glad you asked. Interestingly, we recently had a presentation here from a previous mentor of mine who also happened to be a mentor of one of the kines faculty here. His name was Scott Powers, and he and this other faculty member had done some work looking at exercise as a model for studying recovery from mechanical ventilation. So there is this phenomenon called ventilator-induced diaphragm dysfunction, which basically is a way of saying that when someone's on mechanical ventilation for a while, the diaphragm becomes dysfunctional, and the longer they're on mechanical ventilation, the more difficult it is to wean them off of the ventilation. And of course, as you know, in addition to COVID, there are a number of applications of this, as Lonnie alluded to, with respiratory failure, heart failure, surgeries, and coma, and so forth. But this dysfunction occurs quite rapidly with the diaphragm. by comparison, if we look at the diaphragm and compare it to the soleus, which is a lower leg muscle, as you see there, we see that after 18 hours of rest in the soleus is still capable of producing same force that it could prior to that rest. But after 18 hours of mechanical ventilation, we see a 30% force reduction in the diaphragm. And within a day, we see as much as 50% of force reduction by the diaphragm, which of course then means it's more difficult for a patient to breathe on his or her own. And so this is a really significant concern for us, especially with COVID, when you think about the length of time that some of these folks are on ventilators. It's quite lengthy, and weaning them off of ventilation is really, very challenging. And so we wanted to study this, and we know that exercise optimizes muscle function. And so we were wondering if we could identify the cellular signaling mechanisms and try and activate these in the diaphragms of patients on ventilators. So can we somehow trigger these same mechanisms in these patients during ventilation? And so there have been some studies, and I'll be really brief here instead of getting into all the details. There have been some studies that have identified heat shock proteins as being very important in maintaining the function of the diaphragm. And so this graph here is a little presentation of the force production at a given frequency of stimulation, but we'll just say the force production of the diaphragm. And you have several conditions here. And these, of course, this is in animal models, but these first three really, these three, I guess they're sort of superimposed on each other a little bit. There's three here that are the control condition, that is mice that were not pre-conditioned, were not on mechanical ventilation or anything of that sort. And then these other three conditions, this one, and this one, is the force production of the diaphragm on mice who were mechanically ventilated. And you see here, these that were mechanically ventilated and under a couple conditions with a heat shock protein blocker, as well as just a saline solution, their force production was way low. But those who were mechanically ventilated and had an exercise preconditioning phase and heat shock proteins were not blocked, their force production was much more like that of the mice or the animals that were not being mechanically ventilated. And so we believe that the exercise-induced activation of heat shock proteins could play an important role. Of course, with patients, human patients, you can't predict that they're going to need mechanical ventilation. So you cannot use exercise as a treatment to raise these heat shock proteins. But there are pharmacologic agents that are being investigated that could raise these heat shock proteins. And so one of them is BPG, or BGP rather 15, which supports the expression of heat shock protein 72. It's not been FDA approved for this particular purpose yet, but what we see, and if you look here on this figure, these are young mice and older mice force production, and you can see just an effective age there. And this is young mice and older mice force production after 5 days of mechanical ventilation. And this is young mice and older mice after 5 days of mechanical ventilation, but with the pharmacologic agent to induce the heat shock proteins. And what we see is an effect that seems to be age dependent. Now, we don't know what might happen in humans, But this drug is being used for it is approved for other purposes. And so we're really at a point now where we're wondering if we can somehow stimulate these heat shock proteins during mechanical ventilation in such a way that will allow us to more easily wean somebody off of a ventilator. And so some of this information that we have acquired, we have gathered through the field of exercise science and kinesiology. So as random as that might seem, all of our departments are really interested and have a vital role in understanding the treatment of diseases like COVID. Of course, kinesiology is a very broad field. That's not the only kinds of things that are going on. We have a lot of different areas that we investigate in kinesiology, many of which have implications for what's happening in our communities and with our students, with our student athletes. And so there's a lot of interest in our Department of Kinesiology with the impact of COVID and how we respond to that. But I thought that was just somewhat interesting and thought I would share that with you. And so now we have some time. I know we have some potential students, I think, here. And so we would be happy to answer any questions that you might have about our programs or anything that might be on your mind. And of course, you have, hopefully you've jotted down our emails, and you can peruse our website. And if questions come up later on, you can always ask. Here we go. Thank you so much for the present. Morgan, you are so welcome. Are you going to be attending Boise State in the fall? You can also turn on your mic if you'd rather speak. That's great. Well, if there's any way that we can help you, just let us know. We'd like to get you plugged into whatever interesting things you would like to be plugged in with, okay? Okay, well, we are really grateful to have the opportunity to share a little bit about who we are. We are going to hopefully have this on YouTube pretty soon, and we will also email that link to everyone. And so if you want to share it with friends, family, whomever, that would be great. We appreciate you stopping in to visit with us this evening. So if there are no more questions then, I will thank our co-presenters and our other guests, and just thank you for checking in with us this evening. And we hope you have, where do we see, here we go. Where do we see Corona going in the next year or so? So who wants to take that on?
That is certainly a Dr. C question.
Yeah. I think, a lot depends on whether we can get a vaccine within the next year. That's possible. But I think that really is, would you agree, folks, that is, one of the crucial questions? Jen, what do you think?
Well, it's not going away, so
Right.
it's going to stay around. And yes, I think a vaccine is probably something we really need to be hoping for.
Yeah, so we're planning on, the university anyway, is planning on the social distancing being in place throughout this next academic year. It could be longer, but we certainly hope not. But so many questions are unanswered. It's so new, and some immunity may be acquired, but we'll have to see. Jen, this is your area really, isn't it?
Fortune telling?
Yes.
Yeah, coronaviruses as a group have been around for a very long time, and they're always going to be around. It's just something that we deal with as a human species. So this particular one will probably still be around, and the key will be if we can create effective treatments for people who are very severely affected and get a vaccine.
Yeah.
So.
I saw some interesting news coming out of Great Britain today with the use of some, I didn't hear quite clearly, some steroid, commonly used steroid, reducing mortality by 35% or something.
Yeah, dexamethasone. Yeah, which is a really easy to access drug. We have it in oncology a lot,
right.
and it reduces inflammation, which makes sense when you think about the biology of the disease. So that's very promising.
Yeah, and it's a really kind of anecdotal, not a peer-reviewed clinical trial, but still it will be now, I'm sure. So yeah, but we need great students to help us figure it out. Because without you all, you're the future. We're counting on you all to tell us what to do in the near future. Okay, well, I really want to thank everybody for coming. And again, just reach out to us if you have questions. We'd be happy to visit with you anytime. So with that, I will stop recording, and I will end our open house. Thank you to everybody.
Thank you, everyone.